back. We're back with another episode of RetFix and Chill, this time with our usual suspects. We have Mike, Nitish, and me. And our topic today is going to be discussing the use of primary vitrectomy versus scleral buckle versus vitrectomy when patients come to us with a retinal detachment. Mike is going to talk about some cases, and we'll go from there. Mike, take it away.
I shall show cases here of retinal detachment without PVR. Okay, so case 1 is a patient who came in with 3 weeks of symptoms. He thought it was related to getting some oil in his eyes. He kept dunking his head into a barrel of water every day for about 3 weeks before realizing that wasn't the answer. And he came in looking like this. He had macular off retinal detachment with numerous tears. You can hopefully appreciate from intratemporally to superiorly. How would you guys approach a case like this?
So you said he was phakic, right?
It is a line of breaks, almost continuous, but not one giant tear. It's multiple small to medium breaks going all the way from the intratemporal aspect through to.
And then there's a little bit of vitreous hemorrhage as well.
There.
Yeah. So, I mean, you have kind of some of the classic high-risk features. You have pathology in multiple quadrants. You have definitely lattice-associated pathology. So there's some presumption of a posterior vitreous base. He's phakic, and there's a hemorrhage. So all of these are the preoperative risk factors that make us a little bit concerned. My treatment of choice in this patient, especially with relatively chronic, he's been off for maybe a couple of weeks, would be a combined scleral buckle with vitrectomy.
Ryan, you start where?
Yeah, me too. With all those breaks very far from each other, I would definitely add the support of a 41 band. I mean, I'm not a 40-50 gigantic scleral buckle guy, but like a nice broad 3.5 millimeter 41 band with a vitrectomy, definitely in this case. I agree with you guys completely. And
would you use gas or oil in this case?
I would do C3.
Yeah, same.
Yeah, so I think you kind of touch on all the important points here. I think there is very early PVR, but it's not, for me, late stage enough where I really changed my management based on that. I agree with all those breaks. I had in the buckles. This is post-buckle vitrectomy laser, F6. Did surprisingly well through his fovea, given how long he'd probably been MAC off for, so I was pretty happy about that. He's been doing well so far. Case 2, a chronic detachment with hypotony, uveitis, and synechiae. So the patient initially presented, she was light perception, pressure was around 3, she had a large choroidal detachment temporally, and the view was not great. So I probably saw better on the apoptosis than I did on my clinical exam. There's something going on supranasally there. Wasn't convinced it was the only break. There was anterior cell, some vitreous haze, and the synechiae 360, a little bit of cataract, but good enough view, I thought, through the lens where lensectomy was not. So how do you guys approach this?
This would be a buckle vit for me as well. Gas versus oil, more of a game time decision, depending on how confident I am that I support the breaks and the view during the case. But I would definitely add the buckle in this case, because oftentimes with gas, you end up with an underfill as these choroidals resolve. These are serous, so the infusion often does end up improving it during the course of the case. But I would use a 6 millimeter infusion in this case just to make sure I don't end up in the suprachoroidal space as well.
Do we think the uveitis is due to chronic retinal detachment or due to an actual underlying inflammatory disorder?
I think it's related to the chronic detachment, but it's always hard to say.
Sometimes you can take a bit of a staged approach to this. If somebody comes in, active inflammation, choroidals, you can put them on, rule out infection, put them on prednisone for a little bit, let the eye calm down. Expecting aggressive postoperative inflammation, I worry that although the lenses are clear, they're not going to remain clear for very long. And so sometimes pushing and rendering these patients pseudophakic first, after quieting the eye, getting a clearer view, and then you can be more confident in the second surgery that you're going to be able to elevate hyaloid. This can all be accomplished within like a couple of weeks. Like you don't have to push them too far down the line. But, having a little bit of more experience over the years dealing with uveitic patients, sometimes taking a slow approach here can actually have long-term benefits.
Yeah, so I think you guys read my mind. So you both hit on the points that I was concerned about. I did do a staged approach like this. I did delay the surgery very long, but I put her on oral prednisone for 5 days, and choroidal resolved. It gave me a better view. I was able to break some of the synechiae as well. So now I was a little bit more confident that those were full thickness brakes easily there. I still did see other brakes, but given the configuration of this situation, the reason I didn't like going straight to buckle VIT was I don't really like buckling patients with eyes that have large choroidals. I haven't had an issue with it, but it always makes me a little bit nervous. And just like Sarwar mentioned, the underfill is always a potential issue for it. If there is an inferior brake, that you can do a little bit of an expansile gas, then you're potentially dealing with pressure problems and already kind of an inflamed eye. So there's potential issues with that as well. An underfill of oil is not necessarily ideal either. So once the choroidal came down, I felt more comfortable just proceeding with a buccal vitrectomy, laser, and C3F8. Used a little bit longer acting gas for this case, just given some of the potential risk factors that she had. She did very well with that. Just like Sarwar mentioned earlier, we train with some of the same people. So I do a 41 band for my buccal vitrectomies almost exclusively, unless I have a good reason otherwise to do either segmental inferiorly or larger band in certain area or tired certain area. Those are
Great
my
case.
cases.
Yeah, I think that illustrates definitely a lot of these points. And I find it kind of challenging actually to predict buckle height if I have somebody with another space occupying problem like a choroidal detachment. And so that's why it's nice to get these eyes a little bit quieter before you go in. I've also, some of my mentors have said, you could do the vitrectomy first, get the eye a little bit flatter, resolve the choroidals, and then put the buckle on at the end and then recheck. I don't know. Have you guys ever tried that?
I hate doing it.
It's not fun.
I mean, it's one thing to tighten it later on, but I hate putting a buckle on after you put ports in and everything. It's
Oh yeah.
a terrible
Yeah.
idea personally. I've gone kind of the opposite route. I used to tighten my buckle later on during the surgery. Now I tighten it before I start the vitrectomy, and that makes the case a lot smoother and quicker.
Yeah, the other thing is, I think it can be hard. People talk about tightening the buckle and like how many millimeters to tighten it. I think everyone has different scleral elasticity and rigidity, so I don't think that works. The amount of induration is different in everybody, so I think it can be really hard. I like the idea of tightening initially and then starting your vitrectomy going with your ports, because I feel like oftentimes if you jack up the IOP, that based on how tight it is to about 30 to 40, you end up with a moderate buckle height, which is what we usually want in these cases anyway.
Yeah, I don't go for like a super low buckle. As you could tell from the photos, I go for a moderate buckle height. So I don't mind doing what Zarwar said. I just tighten it till its IOP is relatively high, and I start my vitrectomy. Usually don't have to adjust it after that.
What's the buckle doing? Like, what is your pathophysiological understanding of the buckle?
You get a little insurance from the buckle to counteract some of the PVR forces that may occur from the residual vitreous. Although some people would say, and I certainly agree to this, I don't think you need to necessarily do a aggressive shave. I think the risks can actually be quite high, but it is important to do a 360 shave, especially in a phakic patient, go in with the cutter with both temporally and nasally, and being patient with the shave, because if you're able to release some of those adhesions, you don't necessarily, you've theoretically released the traction.
Yeah, I agree. I've changed my opinion on buccal vitrectomy since the kind of textbook learning in my fellowship days. To support the vitreous base is always what you read. I don't think that's why buccal vitrectomy is important anymore, to be honest. And I've also changed my placement of buckle a little bit based on my clinical experiences. Isn't based on anything data-driven, I'll be honest. But I think the reason why you see a big difference in buccal vitrectomy success rates in certain studies, it's especially those patients that are high risk with PVR. So I think it supports early PVR and it helps support PVR that develops later on. I think that's the main thing that it does. So I actually started putting my buckles further posterior for that reason, to help support, and if a little bit of membrane forms there, it gives you support down the line. I think that's why it juices my success rate a little bit on the high risk cases.
How far back do you go?
Basically go ballpark 4 millimeter back from the muscle if it's easily accessible. I don't
Gotcha.
Go digging and do like moderately dangerous things to get it that far back. If it gives it to me, I'll take it. If not, I'll just leave it a little bit more anterior. I'm not worried about putting it more anteriorly, but it gives you pretty good support if you're doing a 41 band, even kind of a few millimeters posterior to a break sometimes. I think that's the area that I'm mostly worried about. PVRs and the anterior posterior dimension of where the breaks are most.
Yeah, I like those concepts. I think just changing the curvature of the eye, it's easier to lay down a retina on a surface that's slightly pulled in, right? If this is the entire curvature of the globe and you're trying to get the anterior portions to stay, if they're on a concave surface like this, it's going to necessarily want to pull in. But if it's on a more of a convex surface, it can drape over it easier. That's one kind of theory that I've incorporated. When I have my patients show up for their post-op 6 appointment 1, and if I see on the chart they got a buccal vitrectomy, I'm like, great, happy to see you. Walk in the room with like a smile. Or if I know they've had a primary vitrectomy 2 years ago, I'm like, all right, let's take a close look. So I think it just, and that could also just be bias, right? There's confirmation bias, there's training bias, there's experiential bias, there's bias that we gain in this room just talking to each other. And I think that's what is so challenging about this question, and it's sort of eluded us as a community on what's the right answer, because of training and preferences, and also sometimes the lack of like a clear data, right? And so, I thought it'd be nice to actually kind of go through a couple major papers, and over the years, we've seen a lot of studies come through, right? And in this podcast, we've done a little bit more on focus on like surgical technique and clinical experience, and I thought it'd be nice to actually throw in some actual data. So people usually will immediately turn to this study. So this is the primary retinal detachment outcome study. It's headed by Matthew Starr, Ed Ryan, Yoshihiro Yonekawa. This is a large data set from multiple sites, and it's looking at around 3,000 eyes from 6 centers across the United States, about 60 surgeons. They collected around 250 metrics. Their biggest question they started with, I believe, was basically primary retinal detachment outcomes, adding sclerobuccal versus just vitrectomy alone. And they've also answered other questions: phakic versus non-phakic, age, inferior breaks, 360 laser. So we don't need to go through this in a lot of detail, but I thought specifically relevant to our question today, there's 2 main arms to the study that came out: pro study number 2 and 3. Pro study 2 was looking at the outcomes in the phakic subset of patients. They did sclerobuccal, PPV, and buccal vit, and showed that in phakic moderately complex, the buccal and the buccal vits were superior to just PPV alone. In the phakic subset, they showed that they actually did not have the sclerobuccal only in those cases. Like, I don't think there were enough patients, but they have buccal vits versus buccal vits versus vitrectomy alone. So better anatomic outcomes in combination, but visual outcomes were similar. Another question that I thought we should highlight, because we've been mentioning, is this whole issue of inferior pathology. And so in the patients that had inferior retinal breaks, they were showing that the single surgical success rate was greater with the buccal vit compared to buccal alone. This issue was more prominent in phakic eyes. PVR didn't actually change. There was no difference in single surgery success rates based on technique. And then a recent outcome was where they showed that compared surgeons with high single surgery success rate, and they were more likely to place a buccal on phakic eyes. So that was a nice, interesting point. You have to have confirmation, right? So we do studies, we got to do studies again, we got to do studies again. So then this is another group looking at their own outcomes. So now we have primary retinal detachment repair in eyes with deemed that were high risk for PVR. So this is like sort of Mike's first case, right? There's a lot of negative prospective factors at play: PVR, grade A or B, vitreous hemorrhage, large retinal detachment. You showed one with a choroidal detachment, high duration of the detachment. And they showed that the single surgery success rate in high-risk patients is around 71%. So I think most people would hope that their rates are better than that. But, looking at a great institution here, you're showing that high-risk patients, 71% single surgery success rate. So there's definitely a lot we need to learn here, but they're also showing that combined surgery showed higher single surgery success rate. To counteract that, there was another recent systemic review that looked specifically at, again, the question of inferior retinal breaks. They were looking at Medline, Cochrane databases, identified around 542 studies. We're able to find 8 studies with 1,000 eyes that meet their inclusion criteria, and showed that there was a lack of benefit of adding sclerobuccal to PPV to treat rhegmatogenous retinal detachment with inferior retinal breaks. This is retrospective as well. All of these have a large amount of heterogeneous data from a heterogeneous patient population with a lot of different risk factors that can be difficult to tease apart. But I think, without going too into all of the different potential limitations and flaws and statistic analysis methods, which is kind of the outside the scope of this friendly discussion here, I think it's nice to see that there is some value to individual clinical experience and also patient selection. It seems to be that if we pick the right surgery for the right patient, we're overall going to do pretty well for them, and we may have to go back in, and these are difficult cases with difficult pathology. So I thought I'd just throw that in there in the context of the cases that we've shown. Specifically, it does seem that in phakic patients, there's a mild trend towards better single surgery success rate with a combination surgery with buccal vitrectomy. Vitrectomy does very well alone, and it's not necessarily inferior retinal breaks that seems to be the decision line between the two, because we have conflicting outcomes for data for that. So I want to throw it back to you guys, what you thought about the papers that I showed.
That was a great summary of those very important articles in our field. I think it just goes to show, right, the standardization is really hard. We talk about how some things are rare, like, for example, endophthalmitis. How hard is it to do an endophthalmitis study? With RDs, theoretically, we should be able to better do these studies. But even when we're able to deal with a fairly large surgical volume, there's such a variability from surgeon to surgeon, right? For example, I think there's a big difference between someone who does a 41 band, a 240 band, or a 40-50 gigantic band, and where they place it. And what does one person call a moderate buccal height? How much is someone shaving? So even though we put people into these buckets of buccal vitrectomy, or vitrectomy only, I think it's really hard to standardize that. So I think we've mentioned this before. Sometimes, like you said, Nitish, it's important for us to look at our own data and our own success rates, because we have internal consistency. But between multi-centers, even though we get better numbers, it's really hard to standardize the exact technique because there's differences. And that's why we all learn from each other. That's why we do this podcast.
Yeah, Mike, how are we going to answer this question? What do you think it's going to take to figure this out? Or will we?
It's going to take us a long time, I think. And surgical literature is a total, filled mess, to be honest. And I'm glad that the last 5 to 10 years that people have been taking it a bit more seriously and doing these bigger studies that you mentioned that did a great job. But there's even a review that I found where you're pulling up articles comparing vitrectomy versus buccal for simple retinal detachments. And they found a 67% success rate with scleral buccal, 72% for vitrectomy. I was like, that's astoundingly low. So I don't know how to even compare a study like that to other ones where they're talking about low 90% success rate or high 80s, which most studies are showing. So I don't really know what to make of that. I think one of you touched on it along the way. For me, my personal opinion is I think we are not doing a good enough job of stratifying how high-risk detachment is. And then there's other times where I look at the inclusion criteria and I feel like they were maybe overly lax. So that the Wills PVR study group, one of their criteria for high risk for PVR was 2+ quadrants of detachment. I feel like every detachment that comes through my door has at least 2 quadrants. So, I'm walling off of one, quadrant detachment or something. So I'm rarely bringing those to surgery. I'm usually pneumatic, single drape, 1 quadrant detachment. So it can be pretty tough. But I think we probably do worse on the high risk detachments than we think we do. Just to mention one thing out of that same study group, you had mentioned one of their papers. I think this was a different one of their publications out of a similar cohort. They had a 48.3% success rate for primary vitrectomy for a high risk for PVR RRD. So I think that's also a pretty sobering number. But I'm hoping that as we get more larger studies that are a little bit stricter on their criteria, we'll start to sort out some of the questions that we still.
Right. I almost wonder if we've got the wrong endpoint. Single surgery success attachment rate versus high integrity versus low integrity retinal detachment repair. We have to maybe look at the question in a different way, especially when there's so much more data coming out for basically like pneumatics as to maybe potentially become the primary workhorse again for retinal detachment repair in terms of high integrity and reattachment rate.
Yeah. There's one thing you mentioned that is something that I've noticed in my career. I don't know if there's a ton of studies looking at it. I'm sure it's in a study. I'm not coming up with it novelly, but a primary buccal that is attached at 3 months almost never reattaches. I mean, even when they have a PVD later on, which is surprising to me. I feel like I've seen 3 or 4 remote history of the detachment repaired by buccal that come in reattach. And then I don't feel is the case for vitrectomy. I don't know if you guys have had that that same experience.
Absolutely. What's crazy is, we're talking about all these techniques. I'll share a couple of cases where I thought I did what should work with one surgery, but we ended up having a redetachment. So, are you guys able to see this first case? So this is a pseudophakic guy with nasal breaks. You can see the breaks here on the nasal aspect. I made a drainage retinotomy nasal in the mid periphery, and then about 4 to 5 months later, they came back with an inferior RD. I did a vitrectomy for the first case, and in this case, I used C3 fake gas, and I couldn't find any breaks. So in this case, no obvious breaks, no obvious PVR, maybe possibly a slip break, maybe a little bit of contraction by the drainage retinotomy. What would you guys do in this case as a next surgery to fix this RD?
I think you have to be extremely confident that you have hyaloid elevation in all places here. When we are discussing doing a primary vitrectomy, you got to do that part perfectly. And so at this point, I would probably put ICG down in the eye and at least take a look to see if I have an opportunity to take some peeling down to the areas where it's stiff.
Yeah. What do you think, Mike?
Yeah, I'll say just one rebuttal to that. There's also some papers showing visual outcomes of peeling during retinal detachment. I'm not super aggressive with that, but I think staining at least with triamcinolone for me would be something I'd be doing here. Whenever there's an inferior detachment that looks like this, I put a buckle. So I'd be doing a buccal vitrectomy, trying to peel whatever you can. I don't think you're going to get a super satisfying peel here. Admittedly, I'm a little bit suspicious of the retinotomy site potentially being the source of it, so I can interrogate that area pretty well. I think this patient could do well with the buccal vitrectomy gas.
Yeah, that's exactly what I did. So I stain for all my cases, especially RD cases, unless there's dense vitreous hemorrhage. So I stained again. I did a buccal vitrectomy. I added a 41 band here, and I basically approached it like a standard buccal vitrectomy in phakic patients that we talked about earlier on the episode. And I did try to peel here because there really weren't any inferior breaks. I couldn't find anything. So I tried to put down PFO. I tried to drain around the drainage retinotomy site, and there was nothing that was coming. But given that was the only place, I ended up basically trying to peel ILM over that area. And the concern was that, okay, am I missing some additional breaks, which is why having the buckle is helpful. But the challenge is, in this case, I ended up expanding the drainage retinotomy and basically peeled a little ILM. In this case, I didn't peel macular ILM. As you mentioned, Mike, it's pretty hard. So this is, I ended up doing gas in this case and inferior, like 2 rows of laser demarcation along the inferior aspect of the RD over the buccal crest. Thankfully, this patient has done well. There were no other breaks. You can see the laser marks along the buccal crest. It's a nice moderate height. And you can see compared to before, where there was a small drainage retinotomy, I expanded the size of the drainage retinotomy and lasered all around it. And thankfully, this patient stayed attached over a couple of years now, and I think they'll do well. But this shows that no matter what your initial instinct is, and this was initially just a nasal RD, sometimes it doesn't work out as well, and you need to add a buccal vitrectomy if that's not what you did during the first case. I'll share one more case. This is a video. Can you guys see my window?
Yeah.
So I'll talk through it. This is a patient, a right eye with dense asteroid hyalosis where I couldn't see a break. I did a buccal vitrectomy and the patient did great for about 6 months.
Asteroid's scary, man.
Can't see anything, man. But that's why I did a buccal vitrectomy. So they did great. They had cataract surgery. I'll pause it here for a second. You see here, as the bubble's going away, the retina's attached. There is some early PVR along the inferior aspect of the vitreous base. At the picture at the top here, there's some vitreous base contraction and some early PVR, which is why I was so thrilled that I put the buckle on. But anterior to the buccal crest, you see this fibrous band, and that's contraction of the vitreous base. But thankfully, because I had the buckle, it protected us. And you can really make it out here at the picture at the bottom. You can see a PSC cataract there. So they went and had cataract surgery. And about 6 months later, they started to detach with pre-retinal PVR. You'll see that here at the next photo here. You can see that the retina is starting to detach. There's pre-retinal fibrosis, and the retina finally starts to detach and the fluid progresses. So at this point, what do you guys do here? We talked a little bit about ILM peeling. Is that something you would do here? You already did a buccal vitrectomy. So the main questions are, what more do you do here? And do you add any special maneuvers?
Yeah, this is a challenging scenario. Everybody hates to do it, but looking like you're leaning towards a retinectomy, I do feel like when retina starts to really get tented and foreshortened, and you've already got a buckle in the eye, it's not much you can do. I mean, this retina just wants to contract.
Yeah, no, that's definitely that's definitely a very reasonable approach with aggressive PVR. What about you, Mike?
I'm not a huge retinectomy guy. There's pretty good data that membrane peeling is as effective as retinectomy. That being said, when you already have a buccal vit and you don't have good membranes to peel, and it's not a satisfying peel, that's what I would go to. So I think I'd probably end up optimizing this patient
Great.
as well.
And the nice thing about in this case, I love the situation. The patient's now pseudophakic, so I can be so much more aggressive in the initial case. So as you can see, I already stained, and what I did was with the cutter, I went underneath. I'll go back a little bit here. I went underneath the membranes to try to transect the band. Here I'm peeling the pre-retinal PVR, and you get a little bit of bleeding here. In this case, I actually tried to avoid a retinectomy, so I did do ILM peeling. And I started with a macular ILM peel. You'll see I create an iatrogenic break here with some hemorrhage. Don't like peeling in the periphery. Detached or not, it is really hard peeling the periphery. But in this case, what I thought was interesting, and this was the first time I tried not peeling everything. So I peeled the macular. I peeled just the ILM in the areas of pre-retinal PVR. Peeling ILM just over the areas of pre-retinal PVR can be helpful. Because if you think about it, right, the ILM is a sheet that goes along the entire aspect of the inner retina. Why is it necessary to peel the entire ILM, or is it possible for us to have success with just peeling segments of the ILM? Because then it cannot contract and detach the entire retina. So in this case, what I ended up doing is just peeling over the areas of pre-retinal PVR. And actually, in this case, I ended up doing oil. 6 months later, I took the oil out, and thankfully, the patient is still attached.
Yeah, I mean, I think you did amazing. I think it's pretty hard to just initiate ILM peeling in the periphery, right? It's very thin. The retina is very thin. It can be quite taut. And so that's why I think generating a separation in the posterior pole and then trying to use that to bring it up in a sheet together, because then you know what you've done and what you haven't done. It's way easier to just talk about it on the podcast and sit there and do it by yourself, right? You can be there for like 30 minutes trying to figure that out. So these are all very challenging maneuvers for sure. So I appreciate your approach. I think sometimes maybe peeling over a detached retina can be really challenging. If you want to put like a half bubble of PFO down just to stabilize things, that might actually make peripheral peeling a little bit easier.
You know what's cool though? The pre-retinal membrane. This was true grade C pre-retinal PVR. So I peeled that first, then I stained with ILM. And what was cool is in the areas where I peeled the pre-retinal PVR, there were edges that were already elevated of just the ILM. So I didn't have to necessarily initiate it because I had already peeled the pre-retinal stuff. And that's why I was like, oh, you know what? Why don't I just peel this area? And it actually ended up working out really well. And I think that's what I'm going to try to do going forward. I mean, maybe I'm just not skilled enough like a lot of alloys who can peel ILM all the way out to the posterior vitreous base.
It's tough, especially in detached retina. That's why I don't do macular peels. I should clarify what I meant. I don't peel a lot during detachment. And I think that's why we probably saw those couple of studies maybe suggesting the worst visual outcome. That it's not an easy thing to do, and iatrogenic damage to the retina is legit. So that's why I tried to avoid it there. But I think you did everything that you should have done. It was a nice case, a nice outcome for that patient.
Yeah, I mean, I think the lesson here is like, sometimes your initial instinct, like adding the buckle or not doing the buckle, it doesn't always work because every eye behaves differently. And that's why, we just have to be adaptable and continue to learn from each other. Another great episode, guys. Just want to take a moment to thank, you may notice, that we have some new mics. It's, fun running these podcasts, but, we're lucky that we have the support of some of our surgical partners. In this case, just want to shout out and thank Vortex Surgical for their support and commitment to education and to working with surgeons. So we're thankful to them. Thank you, Vortex.